a graduate from the University of Hong Kong. He did his fellowship in Royal College of Radiologists and residency at the clinical oncology in Hong Kong. And he is currently doing fellowship in radiation oncology in breast and CNS malignancies. Our second presenter is also Dr. Carlos Carmona Gonzalez, who is a medical oncologist who did his training in University of Mexico. He did his fellowship in breast and GI malignancies at Odette Cancer Center, University of Toronto. He also has a PhD in clinical trials from National Cancer Institute in Mexico, and he has clinical interest in breast and GI malignancy, including geriatric oncology. And we also have invited speaker Dr. Deborah Saunders, who is joining us from Sudbury. She's a medical director of dental oncology in the Department of Northeast Cancer Center. And she's also program lead for NCC Clinical Tobacco Initiative Program and past president of International Society of Oral Oncology. Her clinical and research interests are in oral complications of cancer therapy, particularly in head and neck cancer. So, Adrian, please. Thank you.
So thanks a lot for the introduction. I'm trying to share the slides. Yeah. Okay. Then you should be able to see my screen now, right? How do I go to presentation mode? Okay. Right.
Just click. Because you don't see.
Okay.
Okay.
Okay, so thanks a lot for your introduction. Today I'm going to talk.
Can you just minimize the?
Okay, sure. Is it working now?
Those top of the corner. Yeah. Thank you.
Okay, thank you. Okay, so today I'm going to talk about the use of radiotherapy for asymptomatic bone metastasis. I'm presenting on this topic because there's a recently published paper in the Journal of Clinical Oncology exactly on this topic, and that was a phase 2 clinical trial investigating radiotherapy for asymptomatic bone metastasis. I'd like to acknowledge that it's actually Dr. Edward Child's idea for me to present on this paper, because I wouldn't have known about this paper if not for him. So we are going to talk about asymptomatic bone metastasis today. So we will not be discussing any painful bone metastasis, because if there's any pain, that will be symptomatic. We'll also not be discussing cord compression or fracture, because that's again symptomatic. And although there can be asymptomatic oligometastasis, we'll not be discussing that neither, because these are excluded from the trial that we are going to talk about today. So as a starting point, prior to the publication of the trial that I'm going to present, the administration of radiotherapy for asymptomatic bone metastasis is not recommended by any guideline, because there's a lack of clear evidence. So that's a starting point. I mean, many years ago when I first learned about radiotherapy for bone metastasis, we do not give it for asymptomatic ones. And this is the phase 2 trial published in September last year about the role of prophylactic radiation versus standard of care for patients with high-risk asymptomatic bone metastasis. So the background is that skeletal-related events can cause pain and poor quality of life. And with modern imaging, which is becoming more and more sensitive, we can detect these metastases at an early stage, even before they start to cause any symptoms. So nobody is really sure what we can do with these metastases. And so they have this phase 2 multi-center randomized control trial. They include adult patients with more than 5 metastatic lesions and histologically confirmed cancer. They do have a high risk criteria to define the risk of complications, which I have in the next slide, and they need to have a reasonable ECOG status. So this is really how they defined high risk. As long as the bone metastasis meets any one of these criteria, it will qualify as high risk. So it's either bulky metastasis more than 2 centimeters, or it is at risky sites such as a hip, shoulder, or sacroiliac joint. And if it's at the long bone, it has to occupy 1/3 to 2/3 of the cortical thickness. And if it's at the spine, then it has to be at the junction of spine or with posterior element. So any bone metastasis at these locations are usually, they will make the spine less stable than those at other locations. So their study excluded impending fracture, existing fracture, or spinal cord compression because these would be a complicated bone metastasis. The primary endpoint of this study is the number of skeletal-related events, which include the pathological fracture, spinal cord compression, or any orthopedic surgery or palliative radiotherapy. I'd like to add a note here that the decision to give palliative radiotherapy can be a subjective one, meaning that if you already know that the patient had a high dose of radiation before, you may be less inclined to give radiation. So, but the other endpoints are quite definite. And the secondary endpoint in this study included hospitalization and the overall survival. So they have around 78 patients randomized to 2 groups, the radiation group and the standard care group. I'd like to draw your attention to the KPS and the high-risk definition in this table. So, so this is the baseline characteristics table. The performance status and the high-risk definition, mainly bulky disease in both arms, aren't exactly balanced. As you can see, patients in the observation arm, they tend, like 46% of them have a KPS of 90 to 100, versus 62% of them actually have the same like performance status in 90 to 100. So I would say that the performance status might be a little bit better in the prophylactic group, and there are also more bulky disease in the observation arm. So that I will further discuss this point in the subsequent slide. So as for the primary outcome, which is SRE, there is a huge difference between these 2 arms, as 29% in the observation arm versus 1.6% in the prophylactic radiation arm, with a very significant p-value. So so because the decision of giving SRE can be a subjective one, so they did an unplanned analysis, namely that they removed the use of palliative radiation from the definition of SRE, and they can still get a significant reduction in the prophylactic radiotherapy arm. What is quite striking in this trial is that there is a significant difference in the overall survival as well. So, so at a median follow-up of 2.5 years, there is a significant prolongation of the overall survival in the prophylactic radiotherapy arm, with the p-value being 0.018. And as for the other endpoint, there are also fewer hospitalizations in the prophylactic radiotherapy arm. There is no difference in the quality of life, and the treatment-related adverse events were uncommon. So I'm going to talk about how we should interpret the findings of this trial. There are a few things that I think we should look into when we are analyzing the findings of this trial. So we'll talk about the base characteristics, those fractionation, the detection of bone metastasis, and also the mechanism of improved overall survival. But we'll begin with the baseline characteristics. I already mentioned that there are more bulky disease in the observation arm, and also the patients in the prophylactic radiation arm seems to have better performance status, though there is no statistical test run on these parameters. I also note that from the baseline characteristics, we don't really know the type and line of systemic treatment in both groups. And importantly, whether any of these lesions, namely the asymptomatic bone metastasis may actually be oligoprogressive disease. Because if that's the case, then the treatment of these disease using radiotherapy can actually drive the OS difference. And that is not we are expecting, or at least we do not know about these factors. So we think that there is a possibility that baseline characteristics imbalance might have contributed due to the OS difference here. And then dose fractionation of radiotherapy. So this study allowed a really wide range of radiotherapies, ranging from this 8-grade single fraction to 20 grade in 5, or to the dose that is only used in the SBRT. So we have some data suggesting that a longer course radiotherapy may lead to better local control and remineralization, though this is a controversial area. And for spine metastasis, there's also data showing that SBRT might be associated with better local control. But to this point, is it fair to say that the optimal dose fractionation is not known? So even if this is we regard it as a positive study, there remains question about which dose fractionation to use, really. And then the third point is really the detection of bone metastasis. So these bone metastases in the study were detected by cross-section imaging, but the authors did not elaborate on how exactly this is detected. So why is this important? I'm going to show you the result of another trial. So this is a UK Crown study. It stems from the idea that because lots of patients with castration-resistant prostate cancer, they eventually would develop cord compression, which is quite debilitating. So what if we did use MRI, screening MRI to screen for these any like clinical, like radiological cord compression, and then we treat them early. So they're hoping that they can then reduce the chance of any clinical cord compression. But unfortunately, this is a negative study. It means that the use of the screening spinal MRI and preemptive treatments to prevent cord compression did not really improve the time to clinical spinal cord compression. So at least in this very specific population of castration-resistant prostate cancer, it seems that the use of screening MRI is not going to be very helpful in improving the outcome of these patients.
Let me just ask you that.
Yeah, sure.
So that's the cumulative incidence of cord compression?
Yes, the clinical spinal cord compression. So there's no difference between.
Like 2 years.
So I think one of the issues here is that we have a lot of imaging modalities available, and they all have different sensitivities. For example, PET-CT is known to be more sensitive than CT scan. So a bone metastasis that are visible only in PET-CT or maybe an MRI may have a very different profile compared with a bone metastasis that is visible in CT scan. So by lumping all these together, it may not really be very helpful for us to make a decision regarding what is the best way to treat a bone metastasis that is detected in cross-sectional imaging. And the last point I want to make is that is regarding the mechanism of the OS improvement. So we assume that if the OS improvement is mediated by a reduction of the skeletal related event, then we think that there should be a corresponding reduction in the hospitalization as well. Because any life-threatening skeletal related events such as a cord compression or long bone fracture most likely would lead to hospitalization before causing death. But in this study, there is reduction of 7 deaths in the RTR, but only 4 hospitalization reduced. So we think that this really open to the discussion as to whether there are any other causes for the improvement in OS, in addition to the reduction of SRE. So my interpretation is that given the limits of this trial, the findings should best be regarded as hypothesis generating rather than practice changing. And we will need a phase 3 confirmation trial before we change our practice. And ideally, in this phase 3 trial, we should have comparable baseline clinical characteristics. We should have the baseline fracture risk properly assessed by validated tools such as the Morel score for long bones or the SIN score for the vertebra. And it should be preceded by a dose-finding trial that identify the most effective dose fractionation regime, or at a minimal, they will be providing a subgroup analysis for the dose fractionation of radiotherapy, so we know which dose fractionation actually works best to reduce the SRE or to improve the overall survival. And this phase 3 trial should also clearly define how the imaging modality is used to diagnose bone metastasis, and also to describe the cause of death, so we know whether the benefits of OS really comes from a reduction of SRE. And it would also be interesting to have a subgroup analysis to see whether there's any interaction between the use or the type of bone modifying agent. For example, if patient is on a particular bone modifying agent, would it be so effective that they no longer need radiotherapy? So other factors to consider include that, well, in a healthcare system level, if we do imaging to look for asymptomatic bone metastasis, would it divert resources away from other patients in some healthcare system? And also it is important to know that because these lesions are asymptomatic to begin with, so any side effect of coming from the radiotherapy, at least in the short term, is going to affect their quality of life. And also we should also take note of the systemic disease burden, because if we're given a long course of radiation for asymptomatic bone metastasis, that can also delay systemic treatment for a few weeks. And as usual, if there's an impending fracture, then we should consider surgery first. So this is another ongoing trial, the trial protocol was just published early this month. So they're looking at whether prophylactic radiotherapy can work to improve the SRE for asymptomatic spinal disease. Their definition is pretty similar to the trial that I just discussed. And yeah, so this is my conclusion. You need a larger phase 3 trial to confirm finding. And right now, I would say, if there's asymptomatic bone metastasis that do not even meet the high risk definition in this trial, then there's probably minimal role for radiotherapy. So thank you very much. I welcome any questions.
Thank you, Adrian. Yes, please.
Yeah, that was really interesting. I know it was a very small study with very small subgroups. Was there any hint of a difference across tumor types?
Let me see. So they only have like 78 patients, and I don't think they have really any subgroup analysis according to the primary tumor type, but definitely that would be very interesting. If this promise paper is published, I think we will also be looking at whether they did a subgroup analysis according to a tumor type.
Okay, any other questions? Okay, great. Thank you, Adrian. It's Dr. Carlos.
Thank you very much. I'm going to put up my presentation. Should be okay.
Reduce that one and
There you go. Okay, so I guess everybody can. Oh,
we have to stop sharing instead.
okay. Okay. Thank you. Hi. Yeah, hello. Hi, thank you. I'm Dr. Carmona, and I will be presenting today a really fast overview of the evidence that we have for osteoclast inhibition in metastatic breast cancer to the bones. I was asked to keep it at 5 minutes, so I'll do my best. There you go. So basically, as we know, and as we have discussed, bone metastasis can cause substantial morbidity, and pain decreases performance status, decreases quality of life, and these can be presented as what we call skeletal related events, or SREs. And this can be radiation, or need for radiation or surgery to the bone, pathological fractures, hypercalcemia of malignancy, and spinal cord compression. As well, there's and that can be any presentation without symptoms. And there's the symptomatic skeletal events that also has been an outcome that has been measured in several trials. So these osteoclast inhibitors are AKI anti-resorptive agents, bone modifying agents, or bone targeting agents. can significantly reduce the frequency of delayed time to onset of the first SRE and subsequent SREs. Basically, we do have two choices, either bisphosphonates or denosumab, and I will chat a little bit about this. So what is the rationale behind the osteoclast inhibition? So basically, in patients with, this is from historical cohorts, and in patients with metastatic breast cancer prior to routine use of bisphosphonates, almost 50% or more than 50% developed some SRE. SRE occurs on average of every 3 to 4 months in women with lytic bone mets. And on treated arms of older RCTs, the first one that showed that adding osteoclast inhibition actually gave a benefit, indicate that a 2-year cumulative SRE incidence was at 68%. So it was pretty high. So no matter if this is symptomatic or asymptomatic, if we catch it, we have to treat it. But obviously, there will be a couple caveats regarding that. More recent phase 3 trials showed that around 25% will develop an SRE if not treated. And this is obviously interesting because we know that our systemic treatments have gotten better. So we might not be expecting the more than 50% of SREs, but we at least, even with the newest therapies, we are still going to have 25% of patients presenting with an SRE at some point in their journey. So osteoclast inhibition is indicated for the management of metastatic bone disease, no matter if it's symptomatic or asymptomatic, for most patients with breast cancer. Benefits are not dependent on the presence or absence of symptoms. And there are some cases where we can do it by case basis. Basically, patients when we assume or assess that the SREs and SSEs are unlikely, i.e. minimal bone tumor burden. And also if patients are expected to live less than 6 months, also that would be some a scenario where we might not want to offer it, because we do know from other trials that 6 months, at least 6 months of treatment are needed to actually make an impact in these patients. Now we know that there is suboptimal adherence to these guidelines. Actually, between 20 and 50% of patients who are otherwise eligible are not receiving this inhibition treatment to prevent SRAs. That's like in the community. So ASCO, CCO, and ESMO guidelines don't have any preference on which osteoclast inhibitor to offer. And we do have bisphosphonates, parenteral options are zoledronic acid and pamidronate. Oral, we have ivandronate, clodronate, or we have the RANK-L targeted antibody, which is denosumab. And from the bisphosphonate perspective, there was a meta-analysis back in 2017 of randomized clinical trials in metastatic breast cancer that compared bisphosphonate with placebo, and these reduced the absolute risk of SREs, excluding hypercalcemia, by 14%. And it had a significant delay in median time of SRE and improved bone pain and global quality of life. There was no overall survival benefit. And why actually, as you know, as a common practice, we normally use zoledronic acid for this when we are choosing a bisphosphonate. Why we do that? So basically, because when zoledronic acid was compared with pamidronate, they were equivalent in incidence of SRS initially, but after 2 years, it seems like there was a lower overall risk of SRS with zoledronic acid. Oral biphosphonate, when compared with zoledronic acid, not inferiority could not be proved. So we are not sure that they are not inferior. And a meta-analysis showed a greater comparative efficacy between 6 and 20% for zoledronic acid. So if we are going to choose to go with biphosphonate, normally we will go with zoledronic acid, but there are some other, but also using the other ones could be reasonable under certain circumstances. And In terms of dosing interval, we know that initially patients received this treatment every 4 weeks. Then there was a few clinical trials that showed that doing every 4 weeks versus 12 weeks was equally effective and safe. However, there is one caveat. Patients with high burden of disease might benefit for every 4 weeks dosing, particularly for multi-level spinal mets. It seems like there is some analysis that shows that might be better just in that setting. Otherwise, basically, every 12 weeks versus every 4 weeks of zoledronic acid, in this case, basically is the same. So moving to denosumab, there was specifically for breast cancer, there was this a randomized clinical trial and then a patient-level meta-analysis that showed that denosumab, when compared with zoledronic acid, had a reduction on SREs and a delay in median time to SREs. There was also a modest but statistically significant improvement in quality of life. There was no effect on overall survival or PFS, but also we have to take into consideration that that also the way it is given, instead of being an IV injection and being sub-Q injection, sometimes it's easier for the patient. There are some acute, this is not related or has not been related to acute reactions as zoledronic acid, but also in terms of kidney adjustments and hypocalcemia, it seems like hypocalcemia is a little bit more prevalent with denosumab, but other than that, we should decide depending on the best profile for our patient. So there has been some studies. The standard dose still is denosumab, 120 milligrams every 4 weeks. However, there are some studies ongoing, particularly some pragmatic clinical trials, that are trying to show that there is not much difference, or at least not a significant difference, on giving it every 12 weeks. This is not a standard at all at this moment, but might become the standard at some point.
It's my standard.
Yeah, it's your standard. So optimal duration of therapy. So basically, there is no information to know what is the optimal duration. There are some reference that says that we have to continue treatment indefinitely in the absence of excessive toxicity, or there is another option to interrupt biphosphonate therapy after a period of 2 years. And this is because with longer follow-up, the risk of symptomatic skeletal events decreases, but toxicity increases. And it seems like after 2 years, that's when that shift happens. Skeletal events was higher in the first year in another study conducted in Europe, and skeletal events was higher in the first year after diagnosis of bone metastasis compared with in the second year. So it was 38% versus 70%, and then 24%. And what happens if a patient does develop SRE while on therapy? There is limited data to inform the best strategy, but basically we have to continue therapy with denosumab, with either denosumab or biphosphonate, or actually there are some advocates to switch the therapy to like the one that we are not using at that point.
Will CCO reimburse it?
CCOs won't reimburse it. That's the problem. Yeah, we only have approved zoledronic acid every either 1 month or every 3 months. Thank you very much.
Okay, great. Any questions for Dr. Carmona?
Questions? Okay, that's it. That's fair.
Any questions from Zoom participants?
There's there's something in the chat.
In the chat, okay.
Yeah.
Can view in the chat.
Yeah. I was just talking about the.
I see. All right, so we have, sorry, this is the chat.
I'm just putting it over.
No, I don't think we have any questions. It's okay. So we are moving now to Dr. Saunders. Dr. Saunders, please.
Thank you. It's always a challenge to give a talk in 5 minutes. I thought that was great and comprehensive. Thank you for inviting me today to this rounds. I'm talking about the end result of all these wonderful drugs to help our patients during their cancer journey. And every medication has a side effect, as we all know. I'm going to be talking about I don't know why my screen is. I'm going to be talking about the side effect that we see with these bone targeting agents, better known as medication-related osteonecrosis of the jaw. Clinical practice guideline was published in 2019. I was senior author on that and on the steering committee. And this publication included publications ranging from 2009 to 2017 through Embase and PubMed searches. A systematic review was carried out with a multidisciplinary team, and consensus-based guidelines were made on that systematic review, of which I want to tell you had very little randomized controlled trials and phase 3 trials. So before we begin, what is the definition and how do we define this side effect of these bone-targeted agents when we see this in the maxilla and the mandible? We are using medication-related osteonecrosis of the jaw as opposed to just ONJ or osteonecrosis of the jaw, or what was used previously in the early 2000s, bisphosphonate osteonecrosis of the jaw, because we know that there are more than one pharmacologic therapy that is responsible for it. With a special emphasis, this publication did not include anti-angiogenic inhibitors. So this is really mostly on our monoclonal antibodies of denosumab, zoledronic acid, and pamidronate or bisphosphonates. So we define this condition as a patient that has current or previous treatment with a bone-modifying agent in the absence of head and neck radiation, with lesions that have been present for more than 8 weeks on evaluation by a trained dental professional. And when we look at this, it can be defined as a frank bone exposure, which is easy for anyone to diagnose, or this classic fistula probable to bone. And this is where really that involvement with dental specialists, hospital dentists, oromaxillofacial surgeons, your community dentists are able to communicate with you that this is still a defined MRONJ and does require further evaluation. So we know that the increased use of bone-modifying agents will result in more MRONJ in our community and our hospital practices. I see most of the MRONJ for Northeastern Ontario. I have quite a large database. I manage the MRONJ on a daily basis in my practice, either observationally, pharmacotherapy-wise, or surgically. Where we see this more commonly is classically in the mylohyoid ridge of the mandible. We can see it in the maxilla, usually in unhealed extraction sites or little bony protuberances that we call tori. They're kind of like bunions in the mouth that can easily be traumatized by food. And if they're torn, then bone necrosis usually does ensue. So if you look at the top right picture, you can see that there's that protuberance, that kind of bunion-like bone that can easily get traumatized by food. And if it does, and patients are on these medications, MRONJ can ensue quite easily. And again, on the lingual of the mandible, inside of the jawbone is another high traffic area for trauma from food. And we predominantly see this in this region almost all the time. So increasing the use of these medications will obviously result in more observation of MRONJ inevitably, because we see it based on these modifiable and unmodifiable risk factors, which I'm going to talk about right now. So how do we reduce the risk of patients in our practices getting MRONJ? There are going to be patients that are going to get spontaneous bone necrosis no matter what they do or how you educate them or how meticulous their mouth care is. But there are modifiable risk factors that we can educate our patients and our community dentists on looking at those at follow-up and self-evaluation. Prevention is key. This is a recommendation that all patients starting these medications are cleared by a dentist who is knowledgeable in what clearance protocols are necessary to give our oncologists the green light to commence these drugs. So prevention really does minimize the need for dental extractions, the development of dental abscesses and gum abscesses while these patients are too long into their treatment. And you may ask, what is the golden rule for really increased risk in having that dental evaluation if they've already had a bone targeted agent? And I would say 2. So if they've had more than 2 treatments, they're usually high risk if any dental extractions or dental infections start after that. So we do identify whose role is what in the management of this on the dental side. Myself being a hospital dentist, I do manage all of the MRONJ. I also work up all of our patients in our center as we receive referrals from our medical oncologists internally. Our community dentists in our region are responsible for follow-up if they're not on any systemic therapy. I discharge them with an information package to the community dentists. So a comprehensive dental examination, looking at their x-rays, their mouth, and also their gum status is really important prior to starting these medications if possible. And then if everything is good and they don't have anything that needs to be intervened with before commencement, usually follow up every 6 months just to check their mouth is what the guideline paper is recommending. So modifiable risk factors for this side effect is any invasive dental procedures, which would be dental implants, dental extractions, gum surgery, poor oral hygiene, poor compliance to dental care, dentures that don't fit well, which means they are high risk for traumatizing the mucosa. Our diabetics who are uncontrolled, they're at risk for most infections and most complications, and most predominantly tobacco users. So in elective oral surgery, we don't recommend the placement of implants in patients that have a history of the higher dose oncologic dose of bone modifying agents. There are exceptions to the rule. If function is necessary for one implant, informed consent for that patient and having that procedure carried out and communicated with the oncology team and by someone with maybe some expertise like myself, it's still possible, but overall really contraindicated. So if oral surgery is performed in patients, we recommend an evaluation at the 8-week mark after their dental surgery has been carried out, because as per definition, it's usually that 8-week mark we notice if there's impaired healing that has been long-standing. If that extraction site has not healed at that 8-week mark, we can define them as a medication-related osteonecrosis of the jaw, and then they go into a different follow-up practice and would be referred to a dental specialist for further evaluation. So drug holiday has always been the question that we spent a lot of time with our consensus panel discussing this on what our recommendation in this publication was going to be. If you think about the half-life of these medications, it makes it a little bit easier to understand why our panel indicated that there is not only insufficient evidence in the literature, but really for us as an expert panel, it is not, we're not able to make a direct recommendation on drug holiday for these patients. But knowing that denosumab has a short half-life and zoledronic acid and pimidronate have very long half-lives, you can probably automatically know what would be my medication of choice if we could foresee those patients that are going to develop an MRONJ. It is much easier to resolve an MRONJ in a patient who has only been on denosumab than pimidronate and zoledronic acid. For those patients, drug holiday sometimes does benefit, but in the bisphosphonate category, it just doesn't make a difference. And if the benefits outweigh the risks of those patients for their skeletal-related events reduction, then they're better off staying on the medications. So the development of MRONJ in the literature varies quite a lot, from 1.6 to 14.8%. That's quite a bit. I would say it hovers around 10% if I'm looking at my data and the number of patients that I have in my practice for ongoing care. So these dental measures, we need to see them at pre-commencement for dental clearance, and also during their treatments, and definitely especially for the bisphosphonate population, because their risks of ONJ or MRONJ in that population are ongoing, usually for the rest of their life. We have very well-designed clearance protocols for our dentists to follow. It makes it easy. This is very similar. How do we work up a patient prior to an autologous or allogeneic stem cell transplant? And it's all based on their ECOG, their survival, and what they're being placed on these medications for. So I'm not going to go into this too much because this would be more for our dental population for me to explain, but it does exist. So we know that our risk factors are modifiable, preventing dental surgeries, getting patients on board with controlling their diabetes. Tobacco intervention is important in all aspects of our oncology patients, and optimizing their lifelong commitment to oral care, which means seeing a dentist regularly. So education on part of the dentist, the community dentist, understand these side effects and how to manage them and how to follow them up, but also education for our patients and understanding the importance of this and the follow-up frequency. So this algorithm is in the paper. We do use this quite a bit when we're educating our oncology and dental population. But so this would be a regular follow-up. So an oncologist would see the patient, refer to a dentist. That dentist would clear them for treatment or perform any dental treatment that needed to be carried out before commencement of drug. And then that general dentist or hospital dentist could see them on just 6-month follow-up, just checking their mouth. So we use a mask and ISO's oral care guidelines for these patients. This has been adopted by Cancer Care Ontario as well. Cancer Care Ontario has a symptom management guide to oral care, and MRONJ is included in that. So if you want to take a look at that, that has been updated since the pandemic, and I was the chair of that committee. So everything that you're seeing in here is available in your symptom management guide. So I'm not going to spend too much time on this, but it's available for you. So although it has been generally accepted that elective surgical and dental and periodontal procedures are contraindicated during patients being on these therapies, there's always exceptions to the rule. And if we need to perform these to get them out of an infection or to provide better function for them, of course, we just have to inform the patient of the risks. So we do take teeth out, obviously, on patients that are on these medications, but we see them at a follow-up frequency at eight weeks, and we know that there's a very good chance that they could be developing a side effect. Because I work in a hospital, I perform bone biopsies on all procedures that are carried out that are surgical in patients that are on active anti-resorbatives or bone-targeted agents. So the easiest is to reduce the risk and not have to do that. And discussing this with the patients and the importance of their commitment to oral care is really very fundamental. So when we're looking at how we manage this once it starts, how would we manage this type of situation? This is actually quite an easy surgical manipulation of bone, and we call it sequestration of bone. And a lot of the times, looking at this type of lesion in this type of picture would probably just require a simple procedure under local anesthetic. I would follow this patient up in 8 weeks, and they would likely be healed. So simple sequestration of bone is usually happens most of the time, and resolution is often seen. So in those instances where patients develop these either by your visualization in the mouth or the dentist seeing that, a referral to a dental specialist is necessary. Because when we see these types of situations, we need to discern, is this from the medication? Is it dentally related? Could it have something to do with metastatic bone disease, especially in our breast cancer patients, or any other etiology? So the differential diagnosis still has to be worked up to confirm that this is secondary to the patient's bone-targeted agent. So communication, it's really important, but before this paper was published, we didn't have a proper course of communication on how to converse with the oncologist. Yeah, there's a bone lesion there. Does the oncologist need to be worried about continuing their bone-targeted agent? Is there a bone exposure, but is it stable, or is it becoming very aggressive? So in this paper, we did develop terminology to describe the state of the lesion as either resolved, stable, improving, or progressive. So looking at something like this, where you can see with the mirror, this is one of those exposed tori. I wouldn't get overly excited about this. I would converse with the oncologist, let them know that it's there, that feel like this is all under control, and I will see the patient in 8 weeks. So this could totally sequester. It could be like an iceberg where there's a 2 centimeter area of detached bone underneath. But so far, so good. It's something that can be observable and managed. So when we look at the resolved, stable, improving, or progressive, these are easy terminologies for us to communicate with our oncology team on our concern of how well we're able to manage it. And one thing that's important for us to remember is that it doesn't always have to be resolved. In breast cancer patients, we can almost always get resolution, especially if their diabetes is better controlled and they are not smoking. But in a multiple myeloma patient, it's not always possible to have full resolution of these lesions because the myeloma has an impact on their bone as well. And also the importance of communicating that to the oncologist is important because a lesion like this for me in a multiple myeloma patient who is on maybe pamidradate or zoledronic acid would be fine for me. It's stable. It's not progressing anywhere. I'm not going to get full resolution. You're not going to do a full bone resection of a jaw in a multiple myeloma patient. So ongoing surveillance and observation of this patient is what is necessary. So just something to really remember with respect to that. We don't always have to see full resolution in these lesions. So looking at continued follow-up with these patients is essential. We have established that in the paper. I do a lot of education, as does Erin Watson from Princess Margaret Hospital, on educating our dental community on this. It is important for us to all be working together for these patients. So when these lesions are resolved, typically I will refer them back to their community dentist for ongoing surveillance. I let the oncologist know that. And then they go back on regular 6-month follow-up and routine care with their family dentist. So again, reassuring the patient that you got this, that you are working with a team of dental professionals, that if anything occurs, that they either call you or their dentist and make sure that they inform them that they are on a bone-targeted agent so that the differential diagnosis of that lesion is done correctly. We have made this a lot more easy for you as clinicians and our dental professionals to really have some at your desk information through a phone app or on your computer. The World Dental Federation and the International Society of Oral Oncology, both of which are world leaders in oral care, as predominantly ISO oral care and cancer therapy. We've got great patient education that is available on our website, but we teamed up with the FDI, which is a World Dental Federation, over the pandemic and developed what we call Oncolab. If you look at the MRONG section on this, it is the most developed. There are referral forms actually on here for you to print out and mail to your community dentists that allow them to know what you're looking for and the feedback form that you need to clear those patients for drug, as well as mouth care protocols. So if you want to take a look at this, just snap this QR code. I'll leave this on for a few seconds so that you can grab this and take a look at it. This is a dynamic app. We're continually working on it. ASCO, MASC, and ISO are in the process of publishing the updated clinical practice guidelines for osteoradionecrosis, which will be updated on this app shortly after that publication. So thank you for allowing me to present, and email me anytime you have any questions. It's an honor to be here today. Thank you.
Oh, sorry. Thank you very much, Dr. Saunders. And do we have any questions from Zoom participants or here in the room?
Yeah, I just asked you how long would doctor wait to actually practice an elective extraction, or how long do we have to wait and stop the treatment before that?
Dr. Saunders, Okay.
Yeah, so you're if I have to do extractions in a patient and you're referring them to me for a clearance before you start a bone targeted agent, I usually recommend six weeks before commencement. And the whole reason for that is that we know how these bone targeted agents work. They go to sites of inflammation. They don't know if it's lytic disease from bone metastasis or inflammatory disease from dental disease or healing. That is usually the time frame, 6 to 8 weeks, if the patient is ideal for that, to wait before you commence the bone targeted agent. Does that answer your question?
Yes, thank you.
Any other questions?
I have a question about adjuvant. Can you hear? Not sure.
Can you repeat, Andrea?
I have a question about the adjuvant use of bisphosphonates, which is a little bit different than what we were talking about today. But obviously this is more elective. And I'm just, now that we use it so widely, I'm having more complications like iritis and more jaw issues. And I just wondered if you had any pearls around the adjuvant use. I mean, I guess we have a much lower threshold to stop it in those cases.
So when you talk about adjuvant use, are you talking about patients that are taking it like at an osteoporosis dose? Is that what you mean?
So for breast cancer now, we use it at the, well, I guess it is.
Well, it can and it can't. So sometimes
Yeah.
it is a lower dose, sometimes it's an oncologic
Yeah.
dose. Those are the
Yeah.
patients that, yeah.
Every 6 months for 3 years.
Yeah. So those are the patients that we thoroughly go through, knowing that there's a good chance they're going to live another 10 years, where our clearance protocols are much more in depth. We get a lot more aggressive with our clearance than someone who has already had a skeletal event. So that's where the education goes in for the dentist to understand what kind of patient are we looking at. That's where it can be difficult, because that's new for a community dentist to know that they're looking at these, say, a breast cancer patient through 3 different lenses. And in the referral form on the FDI app, it allows you, the oncologist, to click on what are they being placed on this medication for, so that the dentist understands how aggressive their dental clearance is.
Okay, thank you. That's really helpful.
Okay, great. Any other questions? Okay, so thank you very much, all presenters, for excellent presentation, and thank you, Amgen, for sponsorship. Thank you very much.
I feel really sloppy. I don't clear that.